And what a great honour to speak with alongside such distinguished speakers. And Professor Tuamelito's paved the way a little for me in terms of the benefits of lifestyle interventions to prevent type 2 diabetes. What I want to do, so Abd emailed me a while ago to ask would I come along and talk about the NHS diabetes prevention programme. So that is what I will focus on. I'll start with a little bit of background, how we have implemented a national programme. And I also want to share with you the data that we've published to date. If there's time, I'll mention how we've adapted over the last 12 months in the context of COVID, which has been challenging, obviously, for all of us. Could I move to the next slide? Thank you. So I'm a diabetologist by trade. My clinical and academic affiliations are at Imperial in West London. But from 2013, I have also been, half of my time has been spent as the National Clinical Director for Diabetes and Obesity nationally in England. When I came into post, we were already in a situation where vast swathes of the English population were being identified as having high risk of progression to type 2 diabetes, but there was very little in the way of opportunities up and down the country to beneficially empower those individuals to modify that risk. Now, from around 2009, so before my time in the national role, there had been a national health check programme called the NHS Health Checks, which checked people between the ages of 40 and 75 for things like hypertension and hypercholesterolemia. But the check also involved a diabetes filter. The filter was formalised by our guideline group in the UK, the National Institute for Health and Care Excellence, or NICE for short, in their guideline in 2012, entitled Type 2 Diabetes Prevention in People at High Risk. Now, much of this effort nationally was to identify people with undiagnosed type 2 diabetes, but obviously the epiphenomenon there is identifying swathes in the middle category of glucose tolerance. Now, the national guidelines from NICE back in 2012, so almost a decade ago now, recognized the fact that in routine clinical practice, access to and so implementation of oral glucose tolerance testing had fallen away completely, not quite completely actually. Outside of pregnancy, access was very poor nationally. And so identification of both undiagnosed type 2 diabetes and those at high risk was through HbA1c and fasting plasma glucose. So NICE outlined two stages of identification. The first stage is of using a validated risk assessment tool. You can see these online, questionnaire style approach, age, sex, ethnicity, put a tape measure around your middle to measure your waist circumference, and you get a score. And if your score is above a threshold, then you're advised to go on and have a blood test, either an HbA1c according to NICE or fasting glucose. And the ranges for the middle category are HbA1c 42 to 47 millimoles per mole, glucose 5.5 to 6.9 millimoles per litre. Now, that did sit rather controversially when it was published. I think really for many of the reasons that Professor Tuamelito has already outlined, the evidence base from the cardinal type 2 diabetes prevention programs used as the substrate population, those with impaired glucose tolerance on oral glucose tolerance testing. But this was an acknowledgement of the pragmatic approach that had to be adopted for clinical practice. In recent months, obviously, we do have Mike Sampson's Norfolk diabetes prevention study was published, which actually implemented inclusion criteria into a randomized controlled trial of lifestyle versus control based very much on these NICE criteria. And Mike, in that study published very recently in JAMA Internal Medicine, has demonstrated a 47% reduction in type 2 diabetes incidence at, I think, just over the 2-year mark. So while acknowledging that routine clinical practice is not using oral glucose tolerance testing to identify those with impaired glucose tolerance, we do now have good randomized controlled trial evidence base for using these criteria. Next slide, please. So within a year or 18 months in post, the NHS published a strategy document. This was immediately before the 2015 general election, and put a much greater emphasis on prevention of disease, developing a proactive health service rather than what was perceived to date to be a rather almost exclusively reactive approach to illness. And the flagship prevention effort of the NHS in that document was to be a national evidence-based type 2 diabetes prevention program. Following the election, the policy document was adopted into implementation policy, and I will now give you a brief run through how we established the program. So a lovely first talk from Professor Tuamelito about the evidence base sitting behind this. This is a national effort to implement a program sort of universally across the program. Next slide, please. So we began a rollout of the program in the 2016-17 financial year. Just to give you a bit of background, I convened an expert reference group, which I chaired and continue to chair. That's been meeting for 6 years or so now. We drew together the evidence from the cardinal randomized controlled trials, based much of our thinking on those, looked at some of the real world translational studies as well. And with the group, we put together a service specification describing an intervention that we felt would give the best chance of success at preventing or delaying onset of type 2 diabetes in an English NHS environment. The intervention was group-based, face-to-face delivery of a lifestyle intervention focusing on weight loss, better quality nutrition, and more physical activity. It was to be a minimum of 13 sessions over a minimum of 9 months, constituting a minimum of 16 hours of contact time. So that's an outline of the intervention. We procured providers who could deliver on that service specification anywhere across England. Put the providers onto what we call a framework, which gave each local area the opportunity to choose the provider from the framework that they felt best met their local population need. By the first financial year, we covered just over half of the country geographically. By the second financial year, we hit 3/4 of the country. And by summer of 2018, we achieved universal coverage of the program across England. I put that little logo down in the bottom right corner because it also coincided almost identically with the NHS's 70th birthday, which was quite opportune, and saw me on the telly a few times, which was quite exciting. By summer of 18, we'd achieved full coverage across the country. We published our first data set in diabetic medicine earlier that year in 2018 that looked predominantly at the first year and the first 40-odd thousand of attendees on the program. And next slide, please. And that paper just highlighted, so as a national program of implementation, we are required to address healthcare inequalities in a number of dimensions, and I'm just going to show you the cardinal dimension. So if you look at weight loss programs generally, certainly the commercial programs, 85 to 90% of attendees are women. We were achieving 45% attendance on the program in the first couple of years. So the purple, dark purple is the first year, the lighter purple the second year, and these are the first attendees, so they've been referred and have managed to attend the program. So 45% men. The next panel to the right shows you the age distribution. And then the bottom two, really important for us in terms of our requirements as a national program. We were seeing as good attendance, first attendance, from the most deprived quintile as from the least deprived quintile. This is socioeconomic deprivation. And similarly, looking at ethnicity, So we know, of course, type 2 diabetes slightly more likely to befall men, much more likely to befall those from more deprived communities, and much more likely to befall those of Asian, Black, or mixed, and some other ethnicities. The population representation of Asian, Black, mixed, or other ethnicities at this time was around 13–14%, and you can see in the bottom right panel that we were achieving an overrepresentation of those ethnic groups, reflecting their higher risk of type 2 diabetes. But we were pleased with these sort of baseline parameters. Next slide, please. So by the end of December 2018, we felt sufficient numbers and sufficient data on people that had had a chance to pass all the way through the program to look at the early outcomes. Now, we have not yet got data on type 2 diabetes incidence. That will come through in about 2022. So what I want to share with you is from the first 2.5 years of activity on the program up to the end of December 18, I'm going to focus on the weight loss trajectories and the HbA1c reduction trajectories. This data actually was published in Diabetes Care just over 12 months ago now, right at the beginning, January of 2020, just before COVID. Next slide, please. So by that point in time, and I should say that there's a lot of activity going through the program still. We are approaching the 700,000 mark in terms of number of people referred into program, but this data and the analyses are based on the first half of that cohort, I suppose. So these are the first 325,000 referrals. So this is taking a cutoff at the end of December 18. By that point in time, we had 325,000 referrals. Of those, 152,000 had attended an initial assessment, whereby we glean some of the baseline data, we collect more reliable data on ethnicity, etc., and we assign people their group for the group-based intervention. They then go on to attend the group-based intervention, and by that same point in time, we'd seen 96,500 people attend at least one of those group-based intervention sessions. Now, it takes 9 to 12 months it can take up to 6 months to persuade people to attend. Some people will often defer because they're busy at the time of referral. Our providers contact them within a few days, but many will defer. So you need to give it 6 months to realize conversion to attendance of all those that are going to attend. Then you need to give people a year to pass all the way through the program and complete. And so by the end of December 18, we'd had 32,500 who had attended at least one of the group-based intervention sessions and had had sufficient time to complete. And we define completion for the purpose of analysis as attendance at least 60% of the sessions. And just over 17,000 by that point in time had. Next slide, please. This gives you percentages in terms of conversion rates. So this is what you get from a national lifestyle intervention program. So of 100, if you call all of the referrals 100% of the individuals, only 53% will ever attend your initial assessment. 36% will attend at least one of the group-based intervention sessions. You give that 36% a year to complete, and around just over half of them complete. But that means that you're only seeing completion of around 1 in 5 of all of your referrals. Next slide, please. Now, what I'm going to do is focus more data for you just on this cohort. So those that had attended at least one intervention session and had had sufficient time to pass all the way through. Next slide, please. So of those, and I've shown you the numbers here on the left, but that gives a completion rate of those that start at least one session of 53%. Next slide, please. So this is a mixed effects logistic regression looking at completion of the program by our definition as the endpoint, as the dependent variable. And this, because we're required to put such attention to the dimensions of inequality, this is just telling you how we do in terms of completion according to the dimensions of sex, age, ethnicity, deprivation, and baseline body mass index. So the darker blue box is the reference population, the lighter blue, the comparators. And you can see in the top bit there, males are the reference and females, no difference in completion rate by sex. The youngest cohort, under 40 years of age, are the comparator for the next dimension. And you can see that completion improves up to around the age of 70 and then falls off a bit. In terms of ethnicity, the reference is the white population, but we see that Asian and mixed ethnicity have significant lower completion rates. Next panel is deprivation, which with the reference the most deprived, but you as you go up to the least deprived quintile, so you see better completion rates. Rather unfortunately, but I think that's characteristic of most behavioral interventions that have analyzed this dimension of inequality. And baseline weight, we see poorer completion in those with an obese category baseline body mass index. Next slide, please. So now onto the weight loss trajectories. The graph on the right shows you a beautiful dose-response relationship. And so number of sessions on the x-axis, minimum of 13, but many of our providers provided a few more than that. And the weight loss in kilograms on the y-axis. So there's your dose-response relationship. I'll present the completer analysis and the intention to treat analysis separately. So with the completer analysis, mean weight change was 3.3 kilogram weight loss, with over a third, so 37% achieving a weight loss of 5% or more body mass. And on intention to treat, the equivalent numbers are mean weight change 2.3 kilograms weight loss, and a quarter are achieving a weight loss of 5% or more. Next slide, please. So this again, exploring as we are required, and to get the best population reach. We know that both obesity and type 2 diabetes prevalence very much follows these sort of dimensions of inequalities, if you like. So this is a mixed effects linear regression analysis. This is a completer analysis, but the pattern is almost identical for intention to treat. So I'll stick with just the completer analysis rather than repeating, with weight change as the dependent variable. So here, no change according to sex. So this is the independent effects of each of these dimensions. Larger weight loss as the age of the participants increase, with, again, those less than 40, the reference population. Asian and Black ethnicity have a significantly smaller weight loss. Increased weight loss as deprivation decreases, so probably the opposite of what we would like to see. And perhaps not unexpectedly, those with the higher body masses get significantly greater weight loss. So we see significantly greater weight loss for those in the obese and overweight ranges of body mass index. Next slide, please. So this is, again, dose-response relationship, number of sessions attended on the x-axis on the right-hand graph, with mean HbA1c reduction on the y-axis, and again, dose-response relationship illustrated there. Completer analysis, mean HbA1c change was 2 millimoles per mole reduction, and intention to treat 1.3 millimoles per mole reduction. Next slide, please. So again, same setup. I should have said actually on the weight loss graph, more weight loss was to the left, and apologies, rather counterintuitively, less weight loss to the right, and the same pattern for HbA1c. So greater reduction on the left, less reduction on the right. So mixed effects linear regression with HbA1c changes the dependent variable. So despite no differences in completion and weight change by sex, we see significantly smaller decrease in HbA1c in women compared to men. And we see the opposite pattern for age. We saw greater weight loss. So we saw, as age increased, we saw greater weight loss, but as age increases, we see less reduction in HbA1c, which probably reflects some of the properties of HbA1c as a measurement and how it changes with both age and, as we know, with ethnicity. And so ethnicity actually is concordant with the weight loss data that we saw. So Asian and Black ethnicity have significantly smaller reductions in HbA1c. the next panel shows you the relationship, a little less convincing in terms of a sort of linear relationship according to the quintile of deprivation, but not barely significant actually, the differences by deprivation in HbA1c change. But despite greater weight loss in those overweight or obese, we see a less reduction in HbA1c in the bottom panel there. Next slide, please. So to summarize, therefore, we don't yet have data on type 2 diabetes incidence. That will come through in 22. We do have the means we now collect data as part the National Diabetes Audit has been collecting data on everyone with a code in their GP record of diabetes for 18 years now. We now also, through the same mechanism, can collect the data on everyone with a code for the middle category of glucose tolerance. We link that to hospital episode statistics and mortality. So we have the means to follow these cohorts longitudinally to look at their conversion rates to type 2 diabetes, their acquisition of complications of diabetes, and for mortality. But for now, we have weight change and HbA1c change data only. This is encouraging. If you look at the systematic reviews and meta-analyses that were out just before we published this data, we are seeing similar weight changes and might expect, we hope, reductions in incidence in type 2 diabetes of 26 to 30%. We'll await to get that further analysis, and hopefully I can present that to you at some later point in time. Just in terms of the age distribution, which is a concern, a prevention program, we'd like to hit younger ages. We did introduce a pilot program to look at targeting younger age groups, and I'll show you one slide on that data, which is now implemented, I mean, much more rapidly than we intended in terms of translating the digital pilot into action because of COVID. But and we've also now, from this data, we now selectively incentivize through payment to the providers, encouraging the providers to better retain those of non-white ethnicity from more deprived backgrounds and people who are obese. Next slide, please. So this is our digital pilot. We were always determined that the program would be evidence-based, so based on best evidence possible. Huge political pressure back in the day to deliver the program digitally, but we were concerned that there was a lack of evidence in the field at that point. But we did, given the pressures on us, we did launch a pilot. I won't go into the details of how we selected providers for our pilot. The evaluation completed in February of last year in terms of the data collection, actually, and we haven't got all of our papers out because our analysts are redirected into COVID analyses for obvious reasons since that point in time. But hopefully in the next 6 months, we'll have more data on the digital pilot. But next slide, please. An important punchline is this: the yellow bars are the age distribution of those that attend a first show up for the face-to-face versus the grey bars, which are the first log on to the digital program. And you can see that shift in age distribution to the left. Next slide, please. Abd, I'm almost there. The program has been seen as a success so far, politically and importantly in terms of ongoing resourcing, but clinically as well. And the feedback now from general practice after receiving quite a lot of pushback initially, this is now welcomed and seen as an opportunity by our general practice colleagues to provide these people who are identified at big numbers across the country, to provide them with the opportunity to beneficially modify their risk. That's appreciated by general practice. The provisional positive outcomes, early outcome data have enabled us to make the case for increasing resourcing of the program. So we had resourcing for 100,000 participants per year, attendees that is, and that will go up to 200,000 per year by 2024. Next one. So this is my final slide, really, and I won't talk at length. Clearly, for a group-based face-to-face intervention, COVID has had huge impact. our providers were incredibly responsive, actually. Within 3 weeks after our asking in March of last year, they converted their entire curricula to remote delivery through Teams, Zoom, etc. And we have also facilitated choice for people entering the program for the digital programs, although we would prefer to have delayed that until we had all of our data analysed and published. Needs must with regard the inability to deliver the program group-based face-to-face means we also temporarily have what we're calling a direct-to-consumer approach, whereby people can self-refer in because of the difficulties accessing healthcare more generally during COVID times. But this just shows you our referral rates of around 20,000 people referred into the program per month at steady state. And then you can see March of last year and April falling off by 3/4, but subsequent recovery. I'll stop there. I hope that gives everyone a flavour for where we are and how we got to where we are with the programme. Abd, I'll stop there. Thank you.